This month's Southern Medicine podcast is a focus on POCUS, pneumonia diagnosis at the bedside. This topic is important because it shows how POCUS can help primary care providers make quicker, more accurate diagnosis, like catching pneumonia right at the bedside. It's a game changer for patients, reducing delays, avoiding unnecessary tests, and ensuring they get the right treatment faster. In this episode, we dive into a real world case where a primary care doctor used POCUS to diagnose pneumonia in a patient with a cough, leading to a quick and effective treatment. We'll talk about the evidence behind lung ultrasound, what the ultrasound revealed in this case, and how it made a difference for the patient. Join us to explore how POCUS is making primary care more efficient, accurate, and patient focused. Dr. Tatiana Haverluk is an emergency physician and founder of Hello Sono. With 15 years of experience using POCUS in diverse settings, from urban EDs to Everest Base Camp, she is dedicated to extending its benefits to more patients. With Hello Sono, she and her team support practices in building compliant, high quality, and profitable POCUS programs through tailored education and implementation. So, Dr. Haverluk, thank you for joining us today on this topic.
Thank you, Randy. I'm so happy to be back with you here.
Yeah, excellent. So, tell us about this case.
Yeah, and I am really glad we are talking about specifically diagnosis of pneumonia in outpatient setting because there is a push to prescribe antibiotics when they are necessary, right? And POCUS is just such a nice way to have a tool at your bedside where you can see it and be like, well, obviously I'm going to prescribe antibiotics because I'm seeing a pneumonia versus if you're seeing completely clear lungs, you're done. You're probably not going to be giving antibiotics to this patient. So in this case, we have a 52-year-old woman who is pretty healthy, and she's been having 5 days of some cough, fatigue, mild shortness of breath. It all started off with some runny nose, sore throat. Sounded pretty viral, but it's now been 5 days, and she's in your clinic, and you're wondering, am I missing a pneumonia? Is this a super infection? What is going on? So on her physical exam, her O2 sat is 94, so a little bit low. And on her exam, you're hearing some coarse breath sounds on the right. So what's the next step for this patient? And POCUS is performed. That's the next step for this patient to figure out what's going on. And POCUS basically shows an abnormal finding that is consistent with a pneumonia. Actually, one of the findings on there is pathognomonic for pneumonia. So if I know this is a podcast for the most part. I know we're also doing a video,
talk
but
about this. Yeah. Can I describe?
yeah. So in this specific case, we also have the presentation on SMA News online if you want to look it up. But there is a small pleural effusion at the right base of the lung. There are some B-lines. There is an obvious consolidation. And not only that, there are also dynamic air bronchograms. So that means when the patient is breathing, there's actually fluid trapped, air and fluid trapped, and it's moving inside the bronchioles. So this sign is actually pathognomonic for pneumonia. And here you go. You literally got diagnosis for pneumonia in probably less than 5 minutes.
Everyone needs to save money. Ideally, you want to earn interest without having to pay penalties to get your money when you need it. SMA Smart IRA is the answer. You get a guaranteed fixed rate of return protecting you from stock market volatility. You can transfer balances without restrictions or surrender charges. And your funds are kept with Emeritus Retirement, an A-plus rated company founded in 1887. You can make contributions, roll over, or transfer balances from eligible qualified retirement accounts like IRAs, 401ks, simple plans, or deposit new contributions if starting an individual retirement account. Email retirement@sma.org to learn more.
Most people in this case would probably send this person to get a chest x-ray.
Yeah. And then, of course, that's going to be somewhere else or another day or two later. Yeah, yeah. So we're finding out right now. We're able to treat, and instead of delaying for another day or two to get the X-ray, and then that's I've actually sort of been through that whole scenario myself. Love the idea. In fact, I don't know if I shared this with you before, but we had a portable ultrasound hands-on one year, several years back at one of our conferences, and my son happened to be there, and I, of course, volunteered him to be the guinea pig. And so he, it was interesting the things that they could look at and see, and so much that you could do now. Now this was much more extensive. They looked at a lot of different things, but yeah, within just a few minutes, you can look at, I guess, the chest cavity and sort of see the way the wand looks. You can see the fusion or the markers or the patterns that is displayed, and then so what does the evidence say about the accuracy of lung ultrasound compared to X-ray? How to compare the two?
Yeah, I mean, the evidence is actually quite good. It's definitely over and over has been shown to be better than chest X-ray in detecting pneumonia, and pleural effusions
Yeah.
and pulmonary edema, which we can see in patients with congestive heart failure exacerbation. So the sensitivity ranges, but anywhere usually from 85 to 95% to detect pneumonia. For a chest X-ray, the average is around 70%.
Yeah.
And if you take, there was actually another study done a couple of years ago, and it was on elderly patients, specifically admitted patients. And the sensitivity of chest X-ray on those patients was only like 40 something percent for pneumonia. So there's a huge difference.
Yeah.
I think we have honestly a better tool that's also available at the bedside. So why not use it?
Well, and it's also in your case, you're using the tool to do the diagnosis that you're trained to do. The X-ray is not necessarily done by, I mean, it's done by, I mean, I've had X-rays done that were not done properly. So you maybe, excuse me, maybe a lot of that is just that, the technology. I mean, if it's a camera, it's analog, it's film, right? Or I guess even if it's digital, but yeah, I just see that it it takes too long, it takes longer, and it's just not as readily available. And of course, you're having to send and read the X-ray then after you get the X-ray. So, yeah, it just seems like the old way just seems antiquated. Now, talk a little bit about the type of device, the cost for the type of device we're talking about. I know we talked about that on our last podcast, but remind our audience just a little bit about what type of equipment we're talking about to do this.
I mean, when I think about using it in primary care setting, I'm thinking more handheld devices because they're a lot more affordable now. So they range anywhere from $3,000 to about $5,000. You can get quite a good device that
Yeah.
will let you do, some of them have almost like multiple probes in one probe. So you can go from superficial imaging to deep imaging, like the lung or the heart or the abdomen, but still do, look at the shoulder and the knee. So the technology is really out there and it's excellent and it's improving every year. So really check it out.
Yeah, that's good. See, that's very doable, and the reimbursement, I'm sure, is probably pretty good. Um, so how did it improve the patient in this particular case overall? What was the final outcome for this particular patient?
The final outcome is that the patient got to go home on appropriate treatment, which was antibiotics, right? Saving time, saving costs, and having an appropriate treatment. So imagine you delayed this by 2 days and
Yeah,
this patient deteriorated. Her O2 sat is now 92.
yeah,
And that's now this borderline case. It's like, oh, maybe she should be going to the ER. Right. So all of a sudden, you're sending this person to the ER, and who knows what the ER is going to do with her? Is she becoming septic? Does she need an admission or at least an observation for 24 hours to make sure her O2 set is not going down? Right. So now you have a lot more of an expensive visit, but also pretty frustrating visit for the patient if they could have avoided it
You're
altogether.
injecting a ton of risk in. I mean, I envision, well, I have to go get my x-ray, so I'm going to have to navigate the parking deck and the tickets to get into the parking deck, and then I'm going to have to walk into the building and look up a directory and find the right room to get my, in big hospital scenarios, if you're going to a multi-tenant type uh, building to try to find that. So you're up and you're moving around and you're walking from car to, it's just, yeah, there's so many things. You're adding so much risk to it when you really cut all that stuff out. So, very interesting case. We look forward to our next case for March. So thank you for joining us today. This is an interesting case, and yet again, a great um, example of how portable ultrasound is really a game changer.
Awesome. I'm happy to be here and looking forward to the next one. Thank you, Randy.
Thank you. Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.